Good morning, everybody, and welcome all of you to this live program at Orthopaedic Principles. Today, our guest of honor is Dr. Santosh Venkatachalam from the United Kingdom. Dr. Santosh is a consultant orthopedic surgeon with special interest in upper limb surgery, and he practices at the Northumbria healthcare system in the United Kingdom. Dr. Santosh has been active in the FRCS courses in the UK and has also been part of the FRCS exams. So, if you've noticed, Dr. Venkatachalam has lectured several times on our channel in the past, and today it's my great honor to bring back Dr. Santosh Venkatachalam for this wonderful live program on elbow instability. Over to you, Santosh.
Thanks, Santosh, for your kind words, as always, introducing me. I'm an upper limb surgeon. Before I start the presentation, a couple of things I have to say. I'm an FRCS examiner in the UK currently. So the views that I have put forth in this presentation is solely mine, and it doesn't represent anything from the Royal College or the examination board. This is solely for educational purposes. The topic that I've chosen today to talk about is on elbow instability. I put it as part one. If you notice it, there are two. If you think about elbow instability itself, you can look at it in two ways. One would be an acute elbow instability, and one would be a recurrent or a chronic elbow instability. I felt it would be too much to cover everything in one lecture, and that dilutes the message. So I've divided it into two parts. Today we'll cover acute elbow instability. Hopefully at some stage in the near future, we'll cover the chronic elbow instability and the reconstruction aspects to it as well. So elbow joint, you can have a lot of forces going through them. Even though shoulder is the most commonly dislocated joint in the upper limb, elbow dislocation is not uncommon, and I'm sure most of you would have encountered it in your clinical practice at some stage or the other. So we're going to try and cover about the elbow instability when it comes to an acute setting after an injury. So the image on the left, it's more likely to be related to a chronic or a repetitive strain in the elbow and leading on to instability. Whereas the image on the right, you've got somebody falling over on their arm and can present with a dislocated elbow. It's a very commonly dislocated joint in children, and posterolateral dislocation, where the radius and the ulna dislocate laterally. It's the most common. Posteriorly and laterally is the most common form of dislocation you're likely to encounter. Elbow dislocations usually occur as a combination of axial loading, valgus posterolateral force because of the valgus position of the arm, and you have a supination element or the external rotation of the forearm resulting in the dislocation. This was as recent as 2016 in the Olympics. You could see this weightlifter with the axial loading with the weight above his head. Then it has extended beyond his shoulder levels and resulted in external rotation of the forearm. And that's led on to the dislocation. So you can see how nasty it is, and he just had to drop his weight and couldn't do the rest of the qualifiers. So before we start any joint, it is important to understand the anatomy involved in an elbow. The common joints are the radiocapitellar joint and the ulnohumeral joint. So these are the bony components. Then we have the soft tissue components, which include muscles and ligaments. The ligaments on the medial side is the medial collateral ligament. It has three bundles, anterior, posterior, and transverse bundles, starting from the medial epicondyle. And on the lateral side, we have the lateral collateral ligament. Part of it is the lateral ulnar collateral ligament. These take more importance, especially when you have a recurrent instability and you're trying to reconstruct it. So we'll cover a bit more in detail about the anatomy aspects of it when we talk about reconstruction in the chronic instability of the elbow lecture at a later time in the near future, as mentioned before. Then we've got the muscles. There's brachialis in the front, triceps at the back. And these contribute to the stability of the elbow joint itself. So it's a floppy hinge joint. It has a good range, but the functional range, as established in the literature, needs to be around 100 degrees. As long as you're able to get to your face and off, even if you can't extend your elbow straight, even if there is a flexion deformity, but you've got a 100-degree range, most of the activities of daily living can be performed. So post-injury on the elbow, flexion deformity is quite common. Most patients don't regain full extension, or they just go up to neutral. They don't have that -10 that they had before, but functionally it may not bother them too much, or they may not even notice that it's a big problem. So the stabilizers, if you think about it as structures in the front, medial, lateral, and posterior, and then look at the bones, then the ligaments and the muscles, that'll give you a reasonable idea as to what's going on. And depending on what structures are damaged, you can address what needs to be done further after that. So in the front, we have the coronoid process, which is an important anterior stabilizer. Then there is the brachialis muscle and the anterior capsule. And the back, we have the olecranon process, complementing what is in the front in the form of coronoid process. Then we have the triceps muscle and the posterior aspect of the capsule. The lateral column involves the radial head and the capitulum, along with the lateral collateral ligament complex and the lateral common extensor origin musculature. And the medial involves the medial collateral ligament, the coronoid process as well. The medial facet of the coronoid comes in, and then the medial epicondyle with the medial common flexor origin. So the classic teaching, or the traditional teaching, is that most elbow dislocations start from the lateral side and go on to the medial side, what is described as the Horry circle. But currently, with recent evidence emerging, when we do MRs or investigate them further, we identify that the structures start to get damaged from medial to lateral side rather than lateral to medial side. Only when you have a posterior medial dislocation, the damage starts from the lateral side and goes medially. That follows the Horry circle. But irrespective of the direction of dislocation, the key thing would be to stabilize the elbow so that you can start the elbow to be mobilized as soon as possible. Because the trouble with elbow joints is, unlike other joints, if you immobilize it for too long, it ends up stiff. So if anything more than a week or two of immobilization is bad news in the elbow. If you have to do it any longer than the first couple of weeks, that means the elbow is not stable enough, and you may have to have a lower threshold for stabilizing the elbow sooner, either surgically or with splints or whatever measures you have, and get them to mobilize to avoid the problem of stiffness. So this is an example of an elbow dislocation. Looks fairly straightforward and simple on the X-ray. But when you do an MR, you can see that, as said before, the medial structures are mainly damaged and the lateral structures are pretty much intact here. So you need to understand that the medial structures can go first, and then it propagates laterally depending on the direction of the force and the spectrum of instability. So it starts medially, then we have the common flexor origin that can go, then the lateral ligament can go, and then the common extensor can be damaged. So be wary of the mechanism of injury and the structures that are likely to be damaged, because that will dictate how you're going to manage the patient. So again, what is considered to be, when you look at an X-ray, yeah, that's a dislocation, looks fairly straightforward and simple. You reduce it and you think that should be okay. But then if you were to get further imaging, sometimes the damage can be a lot more than what you see on a plain X-ray, with damage to both the medial and lateral structures. So think of the hidden injury. That's what I'm trying to say. If you look just at the X-rays, you may not identify a small coronoid fragment, or you may not identify you will not be able to identify the soft tissue injury. So have a high degree of suspicion and don't label everything as a simple dislocation and treat them as they are. So the direction of the dislocation will depend on the direction of the force, and what you see would depend on the amount of energy that's gone through. So if it is a transverse force going through the elbow, you can have montagia fractures. If it's a longitudinal force, then you have the SX Lopresti lesion, which is damage to the interosseous membrane along with elbow instability. If it's rotatory, we can have posteromedial or posterolateral instability, and depending on the direction, whether it's lateral or medial, if there is associated bony fractures, if there's more force going through it, you can have a spectrum of terrible triad or a posteromedial facet of the coronoid fracture dislocation as well. So if you look at the x-rays, more often than not, you'll have a reasonable idea as to what the direction of the force is and what the likely mechanism of injury is. Historically, the coronoid fractures have been classified by Regan and Morey or O'Driscoll, where they've looked at the amount of the facet that's been involved and decided whether it needed surgical fixation or not. Classic would be type 3 of both the O'Driscoll and Regan-Morey classification would be to stabilize the coronoid fracture. But there is some recent evidence emerging to suggest that this may not be sufficient in the decision-making process, and we may need to consider each of these fractures in a bit more detail rather than labeling them about depending on the amount of bone that is involved in the coronoid. So this is one of the things that I follow in my clinical practice. It's been published recently, and it seemed logical when you look at it. So if 3 columns are fairly common in orthopedics, distal humerus, spine, so many other areas, in the elbow as well, we try and divide them as 3 columns. There is the medial column or the anteromedial facet of the coronoid. There's the middle column, that is the anterolateral facet of the coronoid, and the lateral column, which will be the radial head. So what we are looking at here is if we categorize these as 3 columns, then we should be in a better position to make a decision as to what structures are injured and what needs to be addressed and how. So any classification system we have should indicate the severity and should guide us with regards to the management principles. So what we have is a 3-column classification. The middle column is like a fulcrum, then you have the medial and the lateral column. As described before, with the Wrightington classification, they classify it as A, B, and C. So in this X-ray, you can see on the left, you have what we would think as a simple elbow dislocation that has been reduced if you look at the X-rays. But if you look closely at the lateral view here, you can just about see a small coronoid fracture. So it might look fairly benign, but if you get further investigations, if indicated, you may have to think whether it's involving the anteromedial facet or the anterolateral facet. And in this scan, we have identified it as an anteromedial facet fracture here, even though it looks like just a tip, what you would categorize as a tip fracture in the plain X-ray. You can also appreciate a small divot in the posterior aspect of the femoral humeral condyle. That's what's called as an Osborne Cottrell lesion, just similar to a Hill-Sachs lesion in the shoulder. So what's the significance of these anteromedial facet fractures? If you leave them and think, oh, it's only a tip, nothing needs to be done, they can come back later with posteromedial instability because you've lost the medial column. A young man in their late 40s or early 50s could be developing posteromedial instability and arthritis. So we need to be wary of diagnosing these fractures and labeling them as simple fractures without actually acknowledging the severity of the injury. So be aware of it. If the medial column is gone, the lateral ligaments would be damaged when you have a dislocation. You've got the fulcrum, but the medial column is gone. The whole elbow can have a posteromedial instability. So it's important to identify these. If it involves the third column, which is the radial head along with the anterolateral facet, then you can have, if it is a severe injury, you can have something like this, an injury to the coronoid along with the radial head. Then you lost the support of the middle and the medial column along with the lateral ligament injury. Then you have to consider some form of stabilization on these columns. The other injury that's commonly encountered would be the terrible triad of the elbow. There will be a coronoid fracture, there'll be a radial head fracture, and an elbow dislocation. So how do you manage these? You have to address where the pathology is. So you have the lateral structures that are damaged, which would be the lateral ligament and the radial head and neck area. Then you have the coronoid as well. So reduce the joint, get some more information, generally with a CT scan that will tell you what is damaged. If it is predominantly a middle column injury, that is an anterolateral facet of the coronoid, along with the radial head fracture, you could either fix the radial head, or if it's not reconstructible, replace the radial head, address the lateral ligament. Then you've got the lateral column stabilized. You may not need to address the small anterolateral facet fracture of the coronoid. So the historical approach has been traditionally to take some sutures through the anterior part of the capsule along with the coronoid fragment, sometimes drill holes through the ulna posteriorly and cinch it down like a buttress to stabilize the anterolateral facet, which is the middle column. But once you've stabilized the radial head and the medial side is intact, you may not need to do that anymore. So if it is bifacetal, where it involves both the anterolateral and the anteromedial facet, then you may have to stabilize the coronoid either through going anterior to the flexor carpi ulnaris between the palmaris longus and the flexor carpi ulnaris, which is the Hotchkiss approach, or you can go through the bed of FCEU and approach the coronoid and stabilize it with various measures like wires or coronoid plates, whatever works in your hand. But it is important to identify the columns that are damaged and address them appropriately. So the options, as I said before, you could fix the radial head if you can. Otherwise, you may have to consider a replacement of the radial head. If you're replacing the radial head, you might be able to see the coronoid from the lateral side. But if you have to fix the coronoid, you may have to go from the medial side and address it with a plate. So the key things, what I want to take away from this lecture for you guys, or all of you, would be that it do not label elbow dislocations as simple unless you're certain that there is no other major structure that are damaged. Think of the hidden injury. Don't look at the plain X-ray and think, oh yeah, the bone is out, we put it back and it should be fine. And the treatment will be dictated based on what you identify as the structures being damaged, what are the soft tissues, what are the bony tissues, and that will dictate your surgical approach and the choice of implants as well. But the main goal is to get them going as soon as possible. So if you're thinking that I'll need to put this elbow dislocation in a plaster for 4 to 6 weeks or anything like that, then you're probably in the wrong route. It might need to be stabilized much sooner so that they can be out of their splint or plaster or whatever and get them moving. And the key part of the treatment would be physiotherapy rehab after whatever you've done, and get them to get the functional range. Otherwise, you'll be in long-term problems with elbow stiffness superimposed on instability, which is the worst of both worlds. Thank you for your time. If you've got any questions or anything like that, feel free to ask or drop me an email and I'd be more than happy to answer those.
Thank you, Santosh, for yet another brilliant presentation, very clear and concise with very clear take-home messages. Just few questions. Santosh, elbow dislocation, I mean, a lot of new things happening in the elbow dislocation, right? A lot of people are talking about elbow arthroscopy as well. So in a simple elbow dislocation where there's no bony fractures, it's pretty straightforward. And even in a very complex one with a lot of fractures, again, it's straightforward. The issue is something in between where you have ligamentous instability with a dislocation. So suppose it's the posterolateral dislocation that we commonly see. What do you think is going to be a ligamentous problem? As you said, if it's a posterolateral type, the injury starts from the medial side and goes laterally. And what kind of residual instability do you expect? Is it medial or posterolateral? And vice versa.
So the common direction of instability is that it is usually posterolateral or the rotary posterolateral instability, depending on the mechanism of injury. So if you're confident based on the mechanism of injury, clinical assessment, and what you find on x-rays, you can treat it as a simple dislocation and get them going straight away. If you're in doubt, the current trend in our trust is usually to do an MR to see what structures are damaged, or even another option would be to do an EUA in the operating theaters to see which structures what is the direction of instability and how unstable it is. And if it is grossly unstable, you may have to address the ligament complex based on the direction of instability. Because if you ignore it, then they can come back in with subtle subclinical instability or gross recurrent instability, needing further interventions or reconstructions at a later stage.
So do you think a reassessment, say around 7 to 10 days, makes more sense? For example, you had a posterolateral dislocation that was reduced and you reassess it at 7 to 10 days and look at instability at 60 degrees as well as 30 degrees. And that is a time that you think about intervention, is it?
Absolutely. So as we said before, don't immobilize them for weeks and weeks and bring them at the standard orthopedic unit of 6 weeks. So see them 7 to 10 days. When the acute injury is settled, you can look at the soft tissues, you can assess the elbow for stability as well. And then if it is stable at that point, you can get them rehabbing because you've got the dynamic stabilizers of brachialis and triceps working on the elbow. But if you're not happy, clinical assessment will guide you as to what exactly is going on and you can take things from there. Absolutely, I agree.
And do you think the angle at which instability occurs, for example, if there's instability at 30 degrees of flexion, that is quite normal, right?
Yeah.
If you have an instability at 60 degrees, is that when you consider it more severe, isn't it?
Yeah, so the degree of instability is based on the clinical findings. So as you rightly pointed out, if it is unstable at higher degrees, then you're thinking it's more unstable. You'd have a low threshold to intervene early, assess them, investigate them if need be with either an MR or EUA. Role of arthroscopy, my practice, I don't do a lot of arthroscopy for acute dislocations because either it is gone or not gone. And in my hands, I tend to do the repairs of the lateral ligament openly with the common extensor origin that's usually avulsed with it. But there could be a role for those avulsion fractures of the coronoid. If you need to think about it, addressing it with an intra-articular technique like an arthroscopy might be beneficial, where you can stabilize them with threaded K wires and things like that can be done. But yeah, I would assess them and then make the decision when I see them in a week or 10 days.
Santosh, the reason I'm asking you about this is it's a very, very common clinical scenario and people are very, very confused about it. Yeah. So that is why I want to make it very clear to whoever wants to listen. So again, if you don't mind, if there is instability at 60 degrees as well as 30 degrees, and if it was a posterolateral elbow dislocation that was reduced, what are things that we expect in MR? Is it, I mean, of course, the common extensor is going to go. And what about medial or lateral? Is it the LUCL or the MCL? Which is the one that you're concerned? And how do you approach that? If both are gone, or what is commonly gone?
Yeah. So commonly the LUCL can be damaged. Okay. Even if the MCL is gone, the benefit of MCL, the advantage of having MCL, even if it's gone, is that most of the activity, unless you're an overhead thrower or a javelin thrower, your MCL being unstable or torn is not going to be a major clinical issue because most of the things, the gravity will assist stabilizing the elbow. So repairing the MCL is not a very common thing that we perform clinically or in the clinical practice. Majority of the times it's a lateral ligament of the common extensor origin that's gone. And once they are stabilized, then we assess on table how it is, because once you have the radial head that is intact on the lateral side, that's a valgus stabilizer, then MCL role may not be as significant. But if it's still opening up, when you assess once you've stabilized the lateral collateral ligament and the radial head is intact or stabilize the radial head, then you may need to consider an MCL, the anterior band of the MCL, to be stabilized.
And what about LUCL? Do you repair it simultaneously?
So the LUCL, generally it avulses from the humeral side. So once you've got the LUCL with the common extensor complex reattached onto the lateral epicondyle, you don't need to
It's a combined, so it's a combined avulsion. The extensor with the humeral attachment of the LUCL, right? And invariably the medial side goes on conservatively unless there is a gross instability on the medial side.
Correct.
And what about the other side? I mean, posteromedial. Posteromedial, again, I think it's more on the medial side injury, and there is a trend towards early surgery on the medial side, is it?
So our current results seem to suggest that once you stabilize the lateral side, functionally they do fine and there is no major problems. The odd occasions when we've done the medial side or the posterior part of the medial collateral ligament, our experience has been that they end up quite stiff. So we have a very high threshold for not doing, unless we are really forced, it's grossly unstable, we wouldn't address it as a routine. It's not part of our routine clinical practice. Majority of the times, once you address the lateral side, the elbow becomes...
No, my question is on if it is a posteromedial dislocation.
Okay. So if it is a posterior dislocation, again, you have to assess what structures are damaged. And if it is the medial side, that is the predominant problem, as I showed in one of the images on the MR, then we would go in and fix the medial collateral along with the common flexor origin. Similar principles as the lateral side.
Okay, so there is a higher tendency to intervene if it's on the medial side. There's a trend in the literature that you go slightly, earlier if it's a posteromedial dislocation, isn't it?
Yeah, because it's likely to be more severe and likely to cause more instability.
Okay, thank you, Santosh. This is a very, very common scenario, and we have had talks on elbow instability, but the reason I went through in detail was the message that we're going to give should be very clear to the audience.
Correct.
And thank you, Santosh. I think that's all the questions that we have. We have covered elbow instability earlier as well, Wrightington classification, and it's still evolving. And I'm sure in a few years' time, we're going to have clear algorithms for the management of, using the 3-column concept.
Absolutely. Yeah.
So thank you so much. And we would really look forward to hosting you another time later part of this year. Thank you so much.